This is the first of a series of short audio casts on a variety of contraceptive topics. To lead off this series, I would like to suggest an approach to how you can deal with a complex patient desiring contraception without a total disruption of office hours. Our patient is a 34-year-old who delivered 10 weeks ago. She's recently stopped breastfeeding, is currently using condoms, but wants interval contraception. Her pregnancy was complicated by chronic hypertension and a seizure disorder. She is currently on carbamazepine and hydrochlorothiazide. She has a past surgical history of a salpingostomy for ectopic pregnancy and a Roux-en-Y gastric bypass procedure. She also has a past history of pelvic inflammatory disease and a history of occasional heavy menstrual flow. So if we look at all the problems she has, which may impact her choice of contraception, you have the medical problem of a seizure disorder and hypertension, as well as past history of pelvic inflammatory disease, the surgical problems of a prior ectopic pregnancy treated with a salpingostomy and a gastric bypass procedure, and the medications that she's on, carbamazepine and hydrochlorothiazide, as well as a menstrual history of heavy flow. And you only have a few minutes to sort this out. So where do you go first? And my recommendation is to use the CDC website dealing with medical eligibility for contraception. This site provides evidence-based recommendation in an easy-to-use format. And at the end, I'll provide the link to the program as well as the other sites unless you already have it. And certainly the app that I'll suggest at the end can be put on your iPhone as well as your iPad. As most of you are already familiar with this, I won't spend a lot of time on it, but again, it is color-coded, green meaning it's okay to use, though light green indicates there may be occasional issues where you have to be careful about use. Dark red means it's basically absolutely contraindicated, that is the method, and whereas pink means there may be an occasional time where you might want to use a particular method. Across the top of the charts are the contraceptive methods. Down the left-hand side of the charts are the various medical or surgical conditions that may be impacted or may impact contraceptive use. In our particular example, if we look at the second to the last line, it lists epilepsy. And we can see that as we go all the way across that line, there is no contraceptive method that would be contraindicated in a woman who has epilepsy. So if we look at the total patient, you can see, again, seizure disorder by itself does not affect the choice of contraception, but her hypertension, although controlled, would mean that you would avoid combined hormonal methods. Her prior PID history and ectopic pregnancy history, again, does not impact choice of contraceptive method, but her use of carbamazepine means that you should avoid the combined hormonal methods and progestin-only pill. Hydrochlorothiazide, again, no contraindications. Prior gastric bypass, particularly since it was a Roux-en-Y procedure, means you should avoid combined hormonal methods and the progestin-only pill. And her heavy menses does not contraindicate use of any method. So the methods are in the green for all of the issues that this patient had, includes the injection or Depo-Provera, the implant, meaning Nexplanon, the levonorgestrel releasing IUDs, as well as a copper IUD. Now, since this patient has heavy menstrual flow, the probably best choice for her would be a levonorgestrel releasing IUD. And that would be part of your discussion when you're seeing her. But you can see that you can move through this fairly rapidly despite the complexity of her issues. So here again are the various ways you can enter into these programs. The first is the main program that we just discussed. The second is a program that suggests management options for certain contraceptive problems. These can be put on your office computer, and obviously going to the App Store or even to the listed websites, you can develop an app that can be put on your iPhone or your iPad. And I think it's important that you familiarize yourself with this particular approach. And in general, once you are familiar with the site, it will only take a few minutes to solve some of the more complicated contraceptive issues that patients have. The second discussion that we will have in this particular webcast is dealing with the efficacy of contraceptives, including the methodology for assessment of efficacy, a brief discussion of perfect versus typical use, and strategies to reduce unintended pregnancy. The method most frequently used to assess contraceptive failure is the Pearl method. And with the Pearl method or Pearl index, you count the number of pregnancies that occur in the time of observation. You then look at the number of women times the total of months of observation, and that's in the denominator, and then you multiply what you derive by 100. Now, if you're dealing with cycles, for example, in a oral contraceptive study, the multiplier is by 13. Now, the pros of this particular approach is it's simple to do. It's good for short duration studies with few dropouts. It's better if pregnancies are distributed evenly over time, but it's a crude rate, and it's poor if failures occur early in exposure. And in contraceptive studies, it tends to favor less fertile couples and better users. So here's two examples of why you get sort of problems in calculating rates based on poorly distributed pregnancies over a period of time, as well as varying durations of a particular study. So we have study A and study B. In both studies, there's 100 women in the studies. And in both studies, 10 pregnancies occur in the first month only, followed by, in study A, a total of 6 months duration of observation for all the women. And in the second study, 12 months duration of observation. And you can see that, again, because of the varying duration of use, and again, all the pregnancies occurring in the first month, study A results in a Pearl index of 20 and study B in a Pearl index of 10. Yet, perhaps if the women in study A had been followed for an additional 6 months, you would have come up with a lower, shall we say, failure rate calculation. So again, this gives the example of why this is not an ideal method, but despite having its problems, the Food and Drug Administration in evaluating contraceptives for efficacy tends to rely mostly on this method, but does require a minimum number of studies that have a goal of follow-up of no less than 12 months. A better approach is the life table approach. It does calculate failure rates for each month of exposure for each woman in the study. Women leaving the study for any reason other than pregnancy are removed from further analysis, though their length of exposure until exit is counted in the analysis. The problems, again, with this study is it's good when pregnancies are not evenly distributed over time, and it does allow you to compare studies with different rates of exposure. But the problem is it's more difficult to do and certainly doesn't solve the problem of dropouts who don't communicate the reason for leaving the study. So as already noted, it is not widely used because of its difficulty of use. So let's briefly talk about contraceptive failure and again the overall use of methods. And we can see in this chart you have a use rate among all women and women aged 15 to 24 years. And you can see among all women, sterilization actually is quite high on the list, and followed by the birth control pill. But in younger women, clearly sterilization is uncommon. Birth control pill use involves roughly 50% of women, as well as a much higher rate of condom use. And for both of these sort of age groups, all women as well as women aged 15 to 24, you can see that the LARC methods are not as high as the use of, say, birth control pills. And this is of some concern since, of course, all of us know that these methods have a much better perfect and typical use rate. And you can see as we look here to the right-hand part of the slide, you can see that the use of a condom has a perfect use rate of about 2%. If you use withdrawal, you have a 4% rate. But more importantly, the typical use rate, for example, of oral contraceptives is as high as 9%. So very high number of failures. And if only condom is used, it's about 18%. Whereas if you look at the IUD, if you look at the implant and Depo-Provera, the typical use rate is a mirror of the perfect use rate, suggesting clearly that we should be recommending these methods preferentially over other methods when we're discussing contraception with our patients. Now, we continue to have, unfortunately, a high unintended pregnancy rate in this country. Although it's dropped to about 45% in the last couple of years, it has hovered around 50% for a long number of years. Poor women tend to have a much higher rate of unintended pregnancy compared to women who aren't poor, and about a threefold increase in their abortion rate compared to women who are not of low income. About 11% of women at risk for unintended pregnancy in this country were not using contraception, whereas the rate is only 3% in the UK and France. Why this is this a problem of access? Is this a problem of education? It's not totally clear. Among women at risk for unintended pregnancy, only 5% use an IUD in this country. The rate is climbing, however, whereas in the UK it's about 6% and as high as 20% in France and other countries. One of the real issues that we have to deal with is problems with access and cost. Copays are still a major barrier in many systems. Health systems such as Kaiser that eliminate or reduce the copay see a higher increased utilization rate. It's unclear now with a new administration how all of this will be addressed, particularly with the threat of the repeal of Obamacare. Certainly reducing side effects and improving counseling will help with reducing the unintended pregnancy rate, and overcoming resistance to the so-called LARC methods, the IUD, Depo, implants, and so forth, is important. And finally, increasing availability of emergency contraception is also helpful, and there are certainly steps that have made this form of contraception, at least some of it, available over the counter. So in summary, I've discussed with you the use of the US MEC material for dealing with a complex patient, and also have talked about the efficacy of contraceptives, including also the differences between perfect and typical use rates, and certainly issues that still are barriers to effective use of contraception.